PAH is pulmonary arterial hypertension, and it differs from systemic hypertension in that it's much rarer in the population, and it involves the pulmonary vasculature only, not the rest of your vasculature system. There is constriction of the pulmonary vessels such that the flow rate, you get higher pressures, and so that is actually the diagnosis of PAH is when the pressure in the pulmonary arterioles goes above 20 milligrams of mercury. How is it diagnosed? So if you have shortness of breath, syncope, things of that nature, you might have questions and consult a doctor, and they'll do a physical exam, including a detailed family history. They'll check maybe your fingernails and your chest. They'll do perhaps a lung X-ray and some pulmonary function testing. Echocardiography is a great tool, non-invasive. All of these things are non-invasive, and they're ways of getting clues of whether or not you may have the disease. And if there are enough clues, then they will perform the diagnostic test, which is invasive, but it is the gold standard diagnostic test for PAH, and that is right heart catheterization. There are a number of genetic genes that are causal for PAH. BMPR2 was the first gene identified back in the early 2000s. And the variants in that gene cause about 80% of familial cases of pulmonary arterial hypertension, but only about 20% of idiopathic. But having said that, getting a diagnosis of idiopathic doesn't mean that you don't have an inherited cause, and you could have a BMPR2 mutation, in which case we then change your category to hereditary. But since the identification of BMPR2, many other genes have been involved, and especially with the advent of exome and genome sequencing technologies, we now know that there are between 20 and 40 genes that have been associated with PAH in the literature. And over time, we can collect genetic and experimental evidence and go back and curate those genes to look at the level of evidence implicating those genes and redetermine which ones may be definitively causal for PAH and which ones we still need more genetic evidence for, and others that we can now refute and say that there's no relationship with PAH. And it doesn't mean their function isn't important, because they might be active in the BMPR2 pathway, but we just don't have enough, there isn't genetic evidence to suggest that variants in these genes cause disease. If we're talking about adult onset PAH, it's typically about, as I mentioned, 80% of those cases will have BMPR2 mutations, and then more rarely you'll find a variant in other genes associated with the disease. But however, if you look at children, they have a much more heterogeneous, both phenotypically and genotypically. Children, there are more genetic causes of PAH in children. Genetic diagnosis allows about up to 40 to 50% of kids to have a genetic diagnosis after testing, and there's a greater variety of genes, including two genes that work in development. So they cause developmental issues in these children, and that can lead to earlier age of onset and severe disease. There's another class of variants that is not seen in the adult population, and those are de novo variants. So those are not inherited variants. They arise spontaneously in the genome of the children, and those are rarer in the population, and we know that those usually have more deleterious effects, and that thus causing the earlier age of onset and often severe disease. We've also found that about 35% of those cases actually are the phenotype is syndromic in nature, meaning that in addition to PAH, they have other associated comorbidities, including other developmental diseases. Sometimes there is degenerative disease. There can be things like Down syndrome and trisomies, and things of that nature. So identifying those genes helps to understand that individual's disease a little bit better. And so, and the last thing I would say about what genes cause disease is that there's while most of the adult onset cases are due to single copy gene variants, and that's an autosomal dominant mode of inheritance, for children you also can see, although rarely, but we do see autosomal recessive forms, and that is when a child inherits 2 copies of a mutant gene. And that, again, provides an answer, or suggests a reason why their disease is earlier onset and more severe. So a lot of people don't understand genetic testing, what it entails, what kind of tests there are, why they should do it, or what are the considerations, or what are the pros and cons, and how should they decide for themselves what's best for them and their family. And that's where the genetic counselors come in. Genetic testing goes hand in hand with genetic counselors, especially if you're at a specialty care center. We have part of the PH team will include genetics and genetic counselors, and those genetic counselors can meet with families or individuals one-on-one to go over to review their particular case, their particular insurance, what kinds of resources the family has, what kinds of questions they have and answers they're looking for. It can talk about whether the disease is familial. Does it run in that family? Is this the first case? And sometimes, actually, if we get a diagnosis, you can go back through the family and identify others that might be at risk that you didn't know about. So some people are open to that idea. Some people don't want to bother their family or scare them if there's a genetic diagnosis. And so the genetic counselor will talk to them and counsel them through this. It's an education and a one-on-one talking through it session. They can also help in contacting or understanding more about the insurance coverage and advising in that kind of way. So there are different types of genetic testing available. In the older days, it was straight sequencing. If you came to the clinic and you thought you had a familial form, they would do straight sequencing of BMPR2 and look for a variant. But nowadays, there are more genes and more causal genes, and sequencing, just straight on sequencing through the whole gene, is not necessary, and it's time consuming. And so now there are panels. There's panels and there's exome and genome sequencing. Gene panels represent a set of genes that are thought to be causal for PAH. And so you can have one blood draw and analyze or look for variants in a set of genes. It could be, and the composition of the gene panels varies from clinical lab to clinical lab. There may be 3 genes on the panel, there may be 5 genes, there may be 20 genes on the panel. These days, it's more likely that there could be, 15 to 20 genes on the panel. But the thing to consider, so those panels are typically cheaper than doing exome and genome sequencing. But that, again, depends on where you live and what kind of coverage you have. But if it's cheaper, then a lot of people will go for that. It does look at multiple genes at one time. However, the composition of those panels varies between labs, and it can also change over time. So one of the things we like to tell people is that if you get a diagnosis, you want to know what genes were on that panel, what did they test, and what is not all gene variants are alike, and you want to make sure that, but your genetics team should be able to weed through what was found and give you the appropriate advice based on those panels. But over time, they can change, and Additional genes might be identified, and some genes might be pulled off of tables or panels because we don't think they're so important anymore. So if you don't get a diagnosis the first time, it's always a good idea to retest a year or two later, or and if that doesn't happen, if it's not accessible to you a year or two later, then you can do it 5 years later. It doesn't matter. You can always redo your analysis. If you're using a panel, though, you have to provide it's another test for them to use another panel or an altered panel. Whereas exome and genome sequencing, it's one blood draw or a buccal swab. You can actually even provide that from home. If you can't get into the clinic, you can get a buccal swab and mail that in, and they can extract DNA from there. And once they get the genomic or exomic DNA sequence, that's a permanent record for you for the rest of your life. You can keep that, and you can reevaluate that over time without having to ask for another test. You can just have your sequence data reevaluated. Now, you might get a diagnosis the first time around, and then you won't have to wait. But if you don't get a diagnosis the first time, you can always reevaluate that data. So there are a number of benefits that you can get from receiving a genetic diagnosis, or things that you should take into consideration when deciding whether or not you want to have genetic analysis done. One of the things is the clinical management of your disease can be changed based upon the genetic diagnosis, and also the diagnosis itself can be less invasive, and that is particularly for pulmonary capillary hemangiomatosis or pulmonary veno-occlusive disease. That is often indistinguishable from IPAH or PAH unless you get a lung biopsy. However, if you do genetics and you get a genetic diagnosis of an EIF2AK4 variant, then you can get the diagnosis without the invasive lung biopsy. And then it also guides therapeutics, and you will be much more likely to be referred for a lung transplantation sooner rather than later. There are sometimes genetic diagnosis can give clues that there might be other organs and systems involved in your disease. An example of a multi-organ phenotype is for ACVRL1 and endoglin. Those variants in those genes are most often associated with PAH, associated with hereditary hemorrhagic telangiectasia, or HHT, and that is now, if you get a diagnosis of HHT, then they will look for cerebrovascular malformations in the brain, liver, intestine, and other organ systems, and that's really important for early detection as another complication or a comorbidity. Two other benefits or things to consider is that if you obtain a genetic diagnosis, you can then inform your family, and you can identify other family members who may be at risk if they would like to have that information. And just because they get a diagnosis doesn't mean that they're going to get pulmonary arterial hypertension, because the gene variants are not 100% penetrant. The last thing that I would mention is that it's important to consider regarding reproductive decisions for either if you have a daughter that's becoming of childbearing age, or there are other family members that are considering deciding what they want to do about raising a family and having children.